Pam Douglas, Mike Gibson coming to you live from AHA 2022. And we're talking about the PRECISE study, looking at different strategies, precision care strategies in CAD. Talk to us a little bit about what you did.
So we tried to address the guideline problem of an effective, non-invasive or invasive for that matter, evaluation of patients with stable chest pain. We know we want to reduce unnecessary testing. We want to get a higher yield of testing, reduce costs and complications, and guide good preventive treatments. But the guidelines are silent on exactly how we should accomplish this. And so we designed a precision strategy, which consisted of a quantitative risk analysis to identify the lowest 20% risk, to assign them to deferred testing, and the rest got CT coronary angiography with FFRCT. And the comparator arm was usual testing of the physician's choice, stress test, direct cath, whatever the physician wanted and thought was necessary in those patients.
And what did you find?
We found a dramatic reduction actually in our primary endpoint, which was a net clinical effectiveness endpoint of death and MI for safety, and cath without obstructive coronary artery disease as the efficacy component of the endpoint. Our hazard ratio unadjusted was 0.35.
Wow. And what drove that of all those things?
Well, the cath without obstructive disease, of course. This is a relatively low-risk population across the entire frame, but there was no significant difference in death or MI or death and MI. So we were happy about that. I'm also happy to say that there were no deaths and no MI events in the deferred testing group, in the group that was assigned to deferred testing. So it's really nice comparison. We have very few trials in cardiology that randomized trials, because randomization was stratified, that compared doing less in cardiology. And so I think that this is a really important component of high quality chest pain evaluations, but we've never examined it before.
And what went into that risk calculation?
The risk calculation is the PROMISE minimal risk score that we developed in the PROMISE trial on about 4,400 patients with CTs, and we modeled no-risk patients, those with no plaque, no calcium, no events. It was 27% of that population. And we modeled it using clinical factors that were available at the time of the initial office visit for chest pain. So something that's very easy to do. You don't, whatever you have. You don't even need labs if you don't have lipids. And that's been validated externally in both Scott Hart and Dan Nycad with an area under the curve of about 0.76.
Wow.
So it's a good predictor. I mean, and it's, the things that you would expect, absence of risk factors, younger age, women. These are the lower risk people. But this gives physicians a tool rather than just say, we'll figure out, guess who's lower risk. And it really outperforms things like the Diamond and Foster traditional tools.
Is it available on an app or something?
It is on the web right now.
Oh, great. Okay.
Or will be once we publish the study.
Great.
But it identified 400. We identified 400 people as 20% of the population as low risk, and they're 200 in each arm, whereas a Diamond and Forster less than 5% was only 100 people.
I see.
So we're actually
reclassified almost
four times as many patients to the deferred category, and we did it very safely.
Yeah. Wow, that's amazing.
Yeah.
Well, I mean, that's amazing to reclassify that many people and maintain safety. Well, congratulations. Thanks for joining us here today, Pam, and thanks to all of you for joining us here live from AHA 2022.